ourselves. Hi, I'm Jane Grande Allen. I am one of the 3 co-chairs of the e-poster session on miscellaneous / potpourri. There's truly something for everyone here. If you aren't familiar with a topic, just wait 5 minutes and it will be a different topic.
3 minutes.
Just wait 3 minutes. 3 minutes. Okay, and then I have 2 co-chairs here.
I'm Elaine Tseng. I'm a cardiac surgeon at UCSF in the San Francisco VA.
And I'm Jonathan Butcher, biomedical engineering at Cornell.
All right. Okay, well,
just,
yeah.
I cannot see all the poster. I don't know why. There is this band, this black band. Here, you can see. So it's covered.
Yeah. There's the black band on the bottom. How can we get rid of the black band? It's covering up the bottom of the poster.
Is it possible to put it full screen or? Okay, I think it's fine.
Okay, well, we'll just remember that it does that for next year. I'm sorry.
No problem. No problem.
Okay, all right.
Thank you.
Go ahead.
Okay. Good evening. I'm Veronica from Brussels. Thank you for the opportunity to present you this experience with the fate of the distal aorta from the European Registry of Type A aortic dissection. Between 2005 and 2021, 3,900 patients underwent surgery for type A aortic dissection in 18 centers. Of them, 205 patients underwent reoperation at the level of the distal aorta. Analyzing the preoperative features, we can see that the patients that underwent reoperation were younger and at a higher risk of any malperfusion. However, analyzing the intraoperative data, we can see that we found no difference in terms of distal operation at the level of the aortic arch. Analyzing the overall mortality, we can see that patients in the reoperation group had a lower risk of mortality compared to non-operation reoperated patients, and this risk is higher in the first period of the study. Therefore, we decided to perform the landmark analysis, removing patients that had a mortality, died during the first 30 days after surgery, and doing that, we found that the 2 curves were similar. To further analyze the problem with the operation at the level of the mortality, we decided to compare the mortality at index operation versus distal reoperations. And we found that there is no difference. The 2 curves were similar. From the random forest analysis, the predictors for reoperations were the dissection of the iliac arteries and the dissection of the distal aorta, and the number of dissected visceral vessels, and also the connective tissue disease, in particular Loeys-Dietz syndrome. Analyzing the reoperation procedures, the majority of the patients required a total arch replacement on the TEVAR. In conclusion, type A aortic dissection repair was associated with a lower rate of aortic distal reoperation, and younger patients, an increased abdominal aortic diameter and the risk of malperfusion had a higher risk of distal aortic reoperation. Distal aortic intervention did not increase the overall mortality up to 15 years of follow-up. Thank you.
So I just have one quick question then, which is, those are your predictors for reoperation, but in your index operation, what was the treatment? Sort of hemiarch, frozen elephant trunk, sort of how much of the distal did you do in the first operation?
We performed, so the distal operation, we performed a frozen elephant trunk in 9 patients that required the reoperation at the first time, and in 200 patients in the no reoperative group. Of course, we have to perform also the analysis of the risk factor, but we found no differences in terms of first operation at the level of aortic arch. So even in case of distal dissection, the two groups were similar in terms of this type of operation at the level of distal aorta. Probably in younger patients, we have to be more aggressive on the distal aorta, but we know, in particular for younger surgeons, the first intervention is quite easier to do hemi-arch instead of a total arch replacement. So it's quite difficult to perform all aortic arch replacement, but in younger patients, I'm sure it could be we have to perform the total arch replacement probably. But as we can see, the reintervention did not increase the risk of mortality. So.
Okay. Thank you.
Thank you.
All right, thank you.
Thank you.
Now we have Luca Zanella. Welcome.
Okay. Thank you very much for this opportunity. I'm Luca Zanella. I'm going to talk about Ross procedure, which involves replacing the aortic valve with the patient's pulmonary valve. The main causes of failure of this procedure was described to be the dilatation of the autograft. For this reason, a lot of reinforcement were developed. These studies aimed to investigate the midterm outcomes of autograft inclusion in Dacron grafts compared with the freestanding root technique. To achieve this goal, we did a retrospective single-center study between 1991 and 2021. In this period, 472 Ross procedure was performed in adults. We included the inclusion in Dacron graft technique, which was 112, and the freestanding root procedures, which was 202. The median follow-up was 8.8 years in the overall cohort, although the median follow-up of the inclusion in Dacron graft was a bit lower than the freestanding root because the inclusion technique was introduced some years after the starting of the program, of the Ross program at our center. As you can see at the Kaplan-Meier curves, the survival and freedom from intervention of the inclusion in prosthesis at 8 years after the Ross procedure was excellent and comparable with the freestanding root technique. The Kaplan-Meier curves was cut at 8 years because at that time we have the 10% of number at risk of patients. We had one case for each technique of in-hospital mortality, and the mortality risk factor were age, diabetes, severe kidney disease, and associated mitral surgery. As you can see at the cost regression for autograft intervention, we can see that aortic insufficiency and congenital malformation were risk factors for reintervention in the total cohort and in the freestanding root. However, they were not for the inclusion in Dacron graft. So we can conclude that prosthetic inclusion technique in Dacron graft was safe, showing excellent survival. And despite the learning curve with this new prosthetic inclusion technique, the midterm freedom from intervention remains comparable to the freestanding root. Moreover, data suggests that prosthetic inclusion technique is superior to the freestanding root to treat patients with aortic insufficiency. However, further studies are required to evaluate the long-term function of autograft in Dacron grafts. Thank you very much for your attention.
So do you perform the Dacron inclusion exclusively at this point, or do you actually tailor it and then use freestanding root for AS, but then AI use the Dacron? How do you make that decision?
So actually, in the inclusion in Dacron grafts, there were more patients with indication for aortic insufficiency compared with one of the freestanding root. Although there were also patients treated for aortic stenosis or for mixed disease. And this makes the findings almost stronger as the group that have a higher prevalence of aortic insufficiency was inclusion in Dacron graft. However, that was not a risk factor for intervention although it was in freestanding root groups where the aortic insufficiency as indication was lower than compared with the group of the inclusion endocrine graft.
Thank you.
Thank you
Right.
very much.
Thank you. Eric, please join us.
Thank you. Let's see. I can see it here. Okay, great. Here we go. This is an interesting case report that we wanted to share with you. So we're doing over 200 valve-sparing root replacements a year in Cleveland. And part of the reason that volume is up is because we've learned to apply this to much more complex patients. And this is a particularly complex patient with adult congenital heart disease, a 29-year-old gentleman. He's actually the son of a patient whose aorta I've been following. Had a VSD repair as a child, and then presented to his home hospital in acute heart failure because he ruptured a right sinus of valsalva aneurysm. You can see the images on the bottom left demonstrate that hole between the aortic root extending into his right ventricle. There was a very large shunt, QPQS 3:1. He came to us after some medical stabilization and diuresis, and we performed an operation. His leaflets looked so good that I really wanted to save them. And so we applied this novel technique that we've used in some of these more complex patients where we don't have a nice rim of aorta to utilize in the situation for a David's procedure by doing what we call a deconstructed David. He had a little bit of a residual VSD underneath his right coronary cusp, and then the huge sort of windsock defect of his sinus of valsalva aneurysm above his right coronary cusp. But by using this technique that you see demonstrated in the cartoon on the bottom left, where we separate sort of the components of the valve and then put them back together, a little different than an annuloplasty plus remodeling. Here we are sewing graft to graft again. We were able to achieve an excellent reconstruction and save his valve. He did very well. He did end up on ECMO afterward because of the impact of his heart failure, but we decannulated him after 3 days, and he was home in 14 days, and his echo and CT scan looked perfect. And I've since seen him in follow-up. He's doing fantastic. His images look great, and we've been able to apply this technique in select patients and expand our utilization. Thank you.
That's amazing. How often do you think you're using this technique now?
So when I first started doing it, I did it in everyone to prove that it was a reasonable way to sort of do this. We did 60 cases in a row, and we've had very good outcomes, and we've got some one-year follow-up on them. But it is a little more work to kind of add another suture line. And so now we're applying it to patients with complex bicuspid valve repairs that have a very deep-seated, the sinking sinus kind of patient. Probably about 10 to 20% of patients are getting this technique. Otherwise, we do a standard David.
Great. Thank you.
Thanks.
Thank you. Okay, our next one of poster number H4 has withdrawn, so we now have George. Thanks.
Thank you. Okay, thank you for the opportunity to present. On behalf of the aortic team at Liverpool Heart and Chest Hospital in the UK, I'm presenting results of a retrospective series of valve-sparing root surgery. And the aim of this study was to look whether there's any impact of valve morphology on outcomes. So we recruited all consecutive patients that underwent valve-sparing root surgery at our institution between 2017 and 2024, and our composite primary outcome was early or late death, valve-related reoperation, or moderate plus aortic regurgitation during follow-up. As you can see, so we've included 334 patients, but for the purposes of the analysis, we excluded the patients that had root replacement, so we were left with 325 patients that had valve-sparing root surgery. As you can see, half of the patients had severe or moderate to severe aortic regurgitation pre-op. And there were quite a lot of concomitant procedures, so 16% of patients had additional complex aortic repairs, hemiarch or total arch replacement. 5% of patients had redo surgery. About 10% of these operations were done in acute type A dissections. In terms of the results, there was no in-hospital or early mortality in this cohort. Our median follow-up was 36 months, and we've had, as you can see in the curves, there was no difference between tricuspid and bicuspid valves in terms of the primary outcome or the presence of moderate plus regurgitation. We did a subgroup analysis in the bicuspid valves and to try to identify factors predictive of the failure of the repair, and we found that leaflet restriction and calcification were negative predictors, and the geometric height of the non-fused cusp was a positive predictor for the outcome. And as you would imagine, tricuspid valves had lower mean gradients during follow-up. So in conclusion, valve-sparing root surgery had favorable mid and midterm results, and there were no differences between bicuspid or tricuspid repairs, and as we included consecutive patients, we showed that this can be performed safely in all sorts of settings. And it seems that leaflet quality and geometric height at initial assessment are predictive of valve durability. Thank you.
Do you do all Davids then?
So
Or do you have it split between?
So the vast majority, 85 or 89% were David reimplantation. There's a mix of remodeling and like isolated double annuloplasty repairs as well. But the vast majority were reimplantation.
Thank you.
All right, thank you very much.
Thank you.
Okay. All right, I don't know, but maybe that has concluded the valve-sparing portion of the of the poster session. Well done all. At this point, I want to invite Daria for poster H6. Thank you.
Thank you so much for the opportunity to present our study. It has been suggested that valve endothelial cells may stimulate pro-osteogenic changes in aortic valve tissue. And the aim of this study was to investigate the role and possible mechanisms of endothelial cells in promoting calcification of valve interstitial cells. And first, we co-cultivated interstitial cells together with endothelial cells, and which enhanced calcification significantly comparing to just monocultures of interstitial cells. And we were wondering, what are the possible mechanisms behind that? Our hypothesis was that extracellular vesicles from valve endothelial cells may carry mediators that instruct valve interstitial cells to calcify. We isolated extracellular vesicles from endothelial cells, and we added them to interstitial cells in different dosages, and then induced calcification. In our model system in vitro, extracellular vesicles do not enhance calcification of valve interstitial cells. And then we compared proteomics profiles between endothelial cells derived from calcified and healthy valves. And principal component analysis plot showed us no clusterization. So most of the proteins were present in both groups of comparison, and only 2 proteins were significantly higher in calcified cells compared to healthy ones. So on the protein level, these cells are similar. 27 and 8 proteins were present only in healthy or only in calcified group, respectively. So to conclude, endothelial cells from calcified valves stimulate calcification of valve interstitial cells. However, extracellular vesicles did not mediate this effect. Endothelial cells may promote calcification in interstitial cells by paracrine factors or direct cell-to-cell interaction, which needs further investigation. Thank you.
This is cool. I have a question. So I'm curious, what was your differentiation strategy to induce the calcification? And then secondly, do you know where the VEX and the VIX ended up, like during the culture period? Like, are they always on top as opposed to mixed inside?
Thank you for the question. So it was 2D co-culture because we are interested in endpoint of calcification and visualize the calcium. So we seeded first interstitial cells, and then on the top we seeded endothelial cells. First, we can clearly see endothelial cells, how they situated on the monolayer, but then after several days, you cannot distinguish endothelial cells.
Interesting. Okay. Thank you.
Thank you.
Thank you. All right. Thank you. Next, let's have Ketel.
So, hello everybody, I'm very pleased to be here today for presenting our research project which focuses on the mitral valve, which, as you know, has a very complex anatomy being linked to the development and the propagation of the disease, particularly the mitral regurgitation, which can be treated since the early 2000s thanks to transcatheter intervention. However, due to its novelty, long-term hemodynamics and biomechanic consequences still need to be addressed, so as the patient anatomy and etiology on the device efficiency. On top of that, it is now being extended to lower surgical risk patients. There is an increasing need to individualize the intervention, to fully understand the device efficiency, and to further improve patient quality of life. So the objective of this study was to develop a patient-specific mitral valve with normal anatomy and function. And to do so, we used patient transesophageal echocardiographic images to 3D print a mold of its valve, in which we pour two different types of silicone to reproduce the rheological behavior of the mitral valve leaflet layer. Between the different silicone, we inserted 16 braided strings to reproduce the role of the caudate engine, and once the valve were obtained, were placed in our cardiac simulator under the same physiological conditions as the patient during its clinical exam. So for the results, we can see that we were able to reproduce the same anatomical characteristics as the patient, and so as its hemodynamical behavior, with also physiological LC mitral valve major principal strain during the systolic period of time. So to conclude, our model is able to reproduce accurately the anatomy, motion of leaflet, but also the hemodynamical behavior of a patient-specific mitral valve, with also inducing physiological major principal strain during the systolic period of time, which could help us moving forward planification in a patient-specific approach to improve the device efficiency and further patient quality of life. Thank you for your attention.
So I like the combination of the two polymers. So which polymer was meant to represent which component of the extracellular matrix?
So we use silicone more elastic to reproduce the atrialis and ventricularis, as they have more elastin, and then we used silicone more strong or robust, if I could say, to reproduce the spongosa and fibrosa layer, which are inside. So we used the elastic one on the periphery and the rigid one as the yellow between the two elastic silicone.
Okay, got it. Right, so dominated by like more of a fibrosa model.
Yeah.
Very interesting.
Yeah.
Okay, cool. Thank you.
Thank you.
All right, so posters H8, H9, and H10 have withdrawn, unless there's someone ready for those. Okay. All right, thank you. So next is poster H11, presented by Haiyang Wei. Okay. So we can skip over that one and maybe get to them later. Poster number H12 is from Tom. Yes.
Okay. So I'm happy to present this work about numerical simulation of the aortic valve in the context of Ozaki procedure. So I'm the last author of this talk, and we are a team of, so I'm Julien Favier, and we are a team of clinicians, clinical cardiac surgeons, and researchers in fluid mechanics. What you see on the left is the three types of simulations we were doing. So we have Ozaki, native valve, and bioprosthesis. And we did this test to see how numerical simulation and fluid dynamic simulation can provide some insights in the new insights in the, some particular surgery of aortic valve. So the Ozaki procedure has been presented in another talk yesterday. It's a way of reconstructing the aortic valve using the patient's own pericardium. And why we want to study it is because it's considered as it can be considered as an alternative to Ross procedure in some cases. It's also very elegant in the way it's built. And but it is underutilized by surgeons, and mainly because there is a lack of knowledge about the hemodynamics which is behind the new autograft compared to native valve or bioprosthesis. So what we did is three simulations: the native valve, which can be considered as the reference, a bioprosthesis, which can be considered as the gold standard, and Ozaki procedure, the alternative. So we are using a numerical tool which is called Lattice-Boltzmann method. So it's a code that solves the equation of the blood flow. In two words, it's used for aeronautics in the lab with, for instance, Airbus or Safran, and we use it for blood flow in this case. What we did is to get the geometry of the native valve, we were using a CT scan and recovering the leaflets based on algorithm. Then we were computing these three cases. What we found is that for the mean velocity, the three cases behave very similarly. But for the maximum velocity, which is here, so you have to believe me, but the green line showed the maximum velocity, which is higher for the bioprosthesis. And in this graph, you see in orange some fluctuations that are due to, so this is the effective orifice area, that are due to a fluttering on the leaflet of the Ozaki valve. And what you see here is the stresses on the wall, which can be computed using numerical simulation. And what we found is that the Ozaki has less stresses on the wall than the bioprosthesis. Take-home message, so we did this study for only one patient, so it's a proof of concept. We are very impatient to run it on other cases and other scans. We found that the bioprosthesis has a higher maximal velocity, that the Ozaki has a fluttering on the left coronary leaflet, and that which is very interesting, that the Ozaki valve has less shear at the wall, wall shear stress at the wall induced by the blood flow, which means that it can be considered as having a better hemodynamics than the bioprosthesis. Thank you.
That's great. I have two questions. One is that it looks like you use the patient-specific valve, but not necessarily the sinuses. So do you think it's affected by the actual patient-specific geometry of the sinuses? And then two, I think one of the things we'd really be interested in is understanding the higher stresses that are in the commissures. So what are the actual stresses on the leaflets themselves between the different procedures?
Okay, I didn't get the second question, but for the first one, indeed the simulations are patient-specific and the results depend on the geometry themselves, because the Ozaki procedure is patient-specific. So, of course, we need to draw more general conclusions. We need to run this test case on more CT scans, more patients. And there is a strong effect of the patient geometry on the results.
Okay, thank you very much.
Thank you.
All right, next we have poster H13 from Kenza.
Hi everyone, I'm Kenza Ramouni, cardiac surgery resident in Ottawa, and I will present our scoping review on patient-reported outcomes, or PROs for short. So traditionally, the cardiac surgery literature has been focused mostly on hard clinical outcomes, such as mortality, myocardial infarction, stroke, or reoperation rates. But in 2013, there was a publication of the Consort PRO guidelines, which basically guide authors to report patient-reported outcomes and to include them in their studies. So based on this, we performed a scoping review of the cardiac surgery valvular trials to assess the proportion of studies that did include PROs as part of their primary or secondary endpoints. Importantly, we included only adult studies, and we excluded studies that compared cardiac surgery trials to transcatheter procedures. So we ended up including 51 studies, and only 16, so that's 31.4%, included PROs, and only 2 studies included the PRO as a primary endpoint. And because of time, I'll just point you to panel B of figure 3, where we see the trend over time. And there is no clear trend of an uptake of more PROs inclusion in the cardiac surgery randomized literature. So the hope is that this scoping review will enlighten the surgical community to hopefully include more PROs in this era of patient-centered medicine. Thank you.
Could you just tell us a bit about what are the specific questions that you ask in the PROs for the patients?
Definitely. So, sorry, do you mean what did we look at in more detail, or what kind of PROs?
No, what kind of PROs you ask
the patient?
Yes,
thank you. Very good question. So PROs are traditionally divided into some domains, which I'm showing in figure 2. So, for example, quality of life is a very common one, health-related quality of life, but also functional status, return to work, how are they feeling well-being-wise, are they satisfied generally with their procedure, and so on. And we looked at each PRO reported over the years as well, and this is what figure 2 looks at.
Great, thank you.
Thank you.
Thank you very much. Okay, poster H14 is presented by Caroline.
Okay, hi, good evening everyone, or as the Egyptians would say, Massa el Khair. My name is Carlijn van der Ven and I am a PhD student at the Erasmus Medical Center. I'm here tonight to tell you something about the work that we've done on the cross-cultural adaptation of the heart valve disease impact of daily life questionnaire, or in short, IDCV. This is a disease-specific questionnaire that measures health-related quality of life in patients with heart valve disease. However, it was originally developed in Brazilian Portuguese and is currently only available in that language, limiting its use outside Brazil. We aim to translate the IDCV questionnaire to Dutch, but a simple translation is not enough. We needed to do a full cross-cultural adaptation. Why, you might ask? Well, language is not just about words, it's about meaning, context, and how people from different cultures experience illness and express impact on daily life. Idioms, emotional expressions, or even certain daily activities may not translate directly or may be interpreted differently across cultures. An example is an item that would ask if patients are able to walk uphill. This is a common part in many areas of daily life in many areas of Brazil, but in the Netherlands, where the terrain is mostly flat, this item could feel irrelevant or even confusing to patients. A questionnaire that does not reflect those nuances could misrepresent the patient's experience or lead to unreliable data. We underwent a 5-step cross-cultural adaptation, which can be seen in Figure 1. We needed 2 rounds of expert committee reviews, after which we received an excellent Dutch version of the IDCV questionnaire, which we now call the modified IDCV. We are now moving forward with testing its psychometric properties in a population of patients undergoing or having undergone heart valve surgery, and patient inclusion has already begun. Next year, I hope at the annual meeting of the Heart Valve Society to present a Dutch version of the IDCV questionnaire that is meaningful for patients with heart valve disease. Thank you, or as the Egyptians again would say, shukran.
That's great. How did you choose that one to begin with?
The subject or
Yeah,
the questionnaire?
The questionnaire.
Well, that's an interesting question. There is the ICHEM, the International Health Consortium of International Consortium of Health Outcome Measurements. I always need to get the abbreviation right. And that has worked with working groups, having patients in there as well. And the patients actually chose this questionnaire to be translated to different languages. And what's nice to mention is that we are also working on a cross-cultural adaptation with the original developers to translate it into English.
Great, thank you.
You're welcome.
Thank you. Okay, for poster H15, I invite Marie.
Good evening, everyone. I would first like to thank the Heart Valve Society for granting me the opportunity to speak today about a well-reported yet insufficiently understood clinical phenomenon called postoperative thrombocytopenia following surgical aortic valve replacement. So, to investigate its occurrence and extent, we conducted a retrospective study including 1,030 patients who received a Perceval valve through AVR. And the pointer is working. Okay, sorry. Oh. These patients were stratified into subgroups based on their valves, their different valve types. And the platelet counts were monitored from the preoperative baseline, so day -1, to the postoperative day 9. Let me first go over some preoperative characteristics. So the cohort was characterized by a mean age of 78, 50% of females, and a mean Euro score of 6.1, indicating that our population was quite filled with elderly patients with a high surgical risk. More than 50% of cases were combined surgeries, indicative of the fact that our cohort was filling quite a lot of real-world complexity. Let's move on to the post-operative characteristics, which are, in my opinion, most important. So, post-operative thrombocytopenia was well prevalent, with 29% experiencing mild, 53% moderate, and 10% severe reduced platelet counts. And important to note here is that even in these severe cases, the complications of bleeding events were quite limited, with 5% revisions for bleeding and 7.5 transfusion for platelets. Let's go over this graph because it's quite an important graph. We see that the platelet drop occurs between day 3 and day 4, but that the platelet count actually recovers to day 9. Important to note here is that even when the valve design altered, that the platelet count trajectories itself didn't alter a lot. And then finally, we did some multivariate analysis to see which factors would be risk factors, and female gender and aortic cross-clamp stood really out, so they should be taken into account. I would like to end on the following note. Post-operative thrombocytopenia is really a very prevalent phenomenon. However, it is quite temporary and in most cases benign. So our data actually suggests a conservative, watchful waiting approach until we get more insights into the root causes that underlie it. Thank you.
Have you compared this with standard surgical AVR? Because this phenomenon certainly happens with TAVR. So a little bit faster time frame for TAVR, but just curious if you checked it with other like stented bioprosthesis.
No, it was only, we only looked at the Perceval valve that was implanted surgically, but I think a comparison would be definitely interesting for the future, indeed.
Thank you.
Okay, thank you. Okay, so the home stretch now, we have poster H16 presented by Bana.
Okay, so my name is Bana. I'm from the University of Toronto, and I'm presenting outcomes of transcatheter pulmonary valve implantation to treat right ventricular outflow tract dysfunction following the Ross procedure. This is a single center study done at Toronto General Hospital. So as has been thoroughly discussed at this meeting, the Ross procedure is the best aortic valve replacement strategy for young and middle-aged patients with aortic valve disease. And the many advantages are listed here. However, one of the most commonly cited limitations for this procedure is that it involves harvesting of the pulmonary autograft, of course, which must then be replaced by a right ventricle to pulmonary artery conduit. And as a result, that creates another possible opportunity for another valve to fail down the line, commonly cited as becoming from a single valve disease to a double valve disease. And so oftentimes this right ventricular outflow tract dysfunction happens via stenosis of the pulmonary homograft or whatever conduit is used. At 20 years post-Ross procedure, the cumulative incidence of RVOT dysfunction is about 20 to 30%. And increasingly, we're seeing use of percutaneous strategies to intervene on the right ventricular outflow tract to treat this. So we sought to review the safety, efficacy, and durability of transcatheter pulmonary valve implantation following the Ross procedure to see how safe it is. And so this was a single center study looking at all the patients who underwent this procedure at Toronto General Hospital between January 2009 and June 2024, which was 20 patients. So it's a small cohort, but it's not a very common thing. And also the median interval between the Ross procedure and the transcatheter pulmonary valve implantation is 18 years. So it takes some time for this dysfunction to develop. So as I said, it's 20 patients, and it included a diversity of different types of homografts that were implanted, including cryopreserved cellularized, cryopreserved decellularized, unspecified because these were coming from all over the world, these patients, and aortic homografts as well. So diversity of different conduits were used. A diversity of different mechanisms of failure were experienced by these patients, including primarily pulmonary stenosis, but also regurgitation and mixed disease. And furthermore, the types of valves that we implant are mixed depending on the size of valve that's being implanted, and also the size. So we use Sapien mostly, but also Melody valves and one venous P valve. So I realize that the text is actually quite small here, but despite this diversity, early outcomes were excellent. So technical success was achieved in 95%, so 19 out of 20 of these procedures, with one having to be converted to a surgical procedure due to embolization of the valve. But otherwise, the hemodynamic results are excellent, both by echocardiography, where the peak conduit gradient significantly decreased. The proportion of patients who have greater than or equal to mild pulmonary regurgitation was significantly increased. It went from 9 out of 20 to only 1. With regards to right heart catheterization, hemodynamics, both peak-to-peak RV to PA conduit gradients, as well as systemic RV to systemic pressure ratios, those were significantly decreased. As I mentioned, one intervention had to be aborted, and otherwise there were no in-hospital complications. And in this figure, you can see in the top 3 panels, it's before intervention. The bottom 3 are post-intervention. The first one is this conduit failed by stenosis. This one failed by regurgitation, and this one failed by mixed stenosis and regurgitation. And as you can see afterwards, how patent the TBVI intervention is, and how the flow is excellent. So with regards to kind of midterm outcomes, so at a median follow-up of 23 months, only one patient had died due to non-cardiac causes, and one patient did have to undergo transcatheter balloon valvuloplasty due to restenosis. But otherwise, this study demonstrates that there is an opportunity to have a minimally invasive intervention to address the possibility of RV to PA conduit or right ventricular outflow tract dysfunction following the Ross procedure. And we're looking forward to following these patients down the line to see how well the interventions perform with longer follow-up. Thank you.
I was just curious, you have a diversity of the types of conduits you used that failed. And do you know what proportion of those were compared to like your total Ross population? So was there a percentage of a certain type that had more failures than others?
Like other index surgeries that required pulmonary implantation?
Yeah, so if you have a diverse set of like, you used like the homograph that's decellularized versus cellular, you know, like all the different types.
Yes.
And you have 20 that failed, but you have over 400 that are still doing well. So like sort of what proportion of the ones that failed among the ones that are doing well, and is there like a difference between the different types of pulmonary substitutes in terms of those that failed?
That's a good question. I actually didn't describe this flowchart. The 400 patients is all transcatheter valve implantations that were done within this range. No, that's right, that's right. And then we excluded any that were non-pulmonary valves. Then from the ones that were transcatheter pulmonary valve interventions, we selected those that had a previous Ross as opposed to surgery for pulmonary stenosis, atresia, tetralogy.
That might be something that you would be interested in looking
for sure
at.
The only difficulty is that there are so few numbers of each different type of homograft that it would require greater numbers to have meaningful information, but for sure, yeah, absolutely.
Thank you so much.
Thank you.
Okay, next we have Shand from Ascension St. Thomas, poster H17.
Good afternoon. My name is Chandra Maya. I'm one of the cardiac surgeons at Ascension St. Thomas Hospital in Nashville, Tennessee. So this is a case report of a 55-year-old gentleman who was diagnosed with carcinoid syndrome with metastatic disease to liver. So initially, they were able to manage his heart failure with diuretics, and he stopped responding to diuretics. And his cancer was metastatic to liver. And he went to a different city for a special protocol where they embolized the liver with chemoembolization. And then after a couple of months, they said his disease is under remission. But in between this, he came into the hospital several times with heart failure, with bilateral pleural effusions after multiple taps. And an echocardiogram showed that all 4 valves were involved. And we didn't see any PFO to explain why the left side was involved. And after failed medical therapy with diuretics, and as you can see there, the video would be better, but here, you can see mitral and tricuspid regurgitation, they were wide open, and how bad the aortic regurgitation is. So we discussed him in our multidisciplinary valve conference, and there was no percutaneous option for all 4 valves, especially in setting of carcinoid. So we recommended high-risk surgery. Because of almost half the liver was gone with ablation, I was worried about his liver and kidneys. So in this situation, I've had reasonable experience with using intra-aortic balloon pump during cardiopulmonary bypass to protect the kidneys and liver. We placed the intra-aortic balloon pump from get-go and did all 4 valves, all 4 biological valves. Like all the cardiac surgeons know which way to do. We went from mitral first, aortic, and then before aortic, I had pulmonic because the exposure was difficult. The pulmonary artery had to be augmented with a patch, and then aortic and tricuspid valve, I did it with a beating heart. So patient had a long operation and prolonged hospital course. I left the chest open because of significant bleeding. We started off with not a normal liver to begin with, and in spite of coagulopathy correction, so I left the chest open. Started bleeding more, had to bring him back the night before, night of surgery. Ended up re-exploring, evacuating. Bleeding was acceptable at that point, closed the chest. 2 days later, you're still intubated, so both chests filled with blood, as you can see here. And I took him back, reopened the sternotomy, evacuated in hematoma. It was all bleeding from the bone edges. And then a few days later, he was extubated, eventually discharged to rehab place 28 days after initial operation. And we followed him every year since then. His carcinoid has not recurred, fortunately. And at 5.5 years, this was just 3 months ago, his echo showed that all 4 valves are still functioning. His RV function is still mild to moderately depressed, which was what before surgery, and LV function is normal with EF normal now.
Congratulations, that's quite a tour de force.
Yeah. I mean, as you know, there are hard operations. And again, many of people have done 4 valves, but getting him 5 years out is hard. It's not up to the surgeon, it's the disease process.
How's his heart?
It's normal now.
Yeah.
His most recent echo. And he has not been in the hospital for any recurrent admissions for heart failure or the liver-related issues since then.
Congratulations.
Thank you.
Thank you. All right. Next we have Eva.
Hello, thanks for inviting us to present our work. It's not working. Okay. Sorry. Okay, so 20 to 50% of patients undergoing a surgical valve replacement will develop postoperative atrial fibrillation, which is a highly under-recognized clinical complication, even though it's associated with high morbidity and mortality rates that may entail extra cost of even $10,000 per patient during the first year. drawing conclusions from previous biomarker studies is limited because of the heterogeneity of the cohorts analyzed. So we aim to understand whether serum markers may predict or infer the underlying pathogenesis of this complication. To do that, we recruited 354 patients with aortic stenosis undergoing elective surgical valve replacement. Blood samples were withdrawn during the 24 hours before the surgery and were dedicated to biomarker studies, including proteomic analysis using Olink technology or validation and target-directed studies using ELISA or Western blot. Multivariate analysis of Olink data revealed that 15 targets might be potentially regulated in patients developing AF after the surgery, and the enrichment analysis suggested that neutrophil degranulation might contribute to it. We next studied in the whole cohort, we validated in the whole cohort, and rather than age and ejection fraction, no other clinical differences were significant between patients at sinus rhythm or developing post-op AF. Myeloperoxidase, a neutrophil degranulation marker, was validated to be different in the whole cohort, along with other markers for cardiac function or endothelial function, like in here, including VAGF members and reelin, which is a lymphangiogenic and inflammatory marker. Moreover, myeloperoxidase was correlated strongly with other neutrophil degranulation markers in here and endothelial function markers in here. Receiving operating curve analysis suggested that only reelin might have a diagnostic potential, and it performed even better than other markers previously found to predict the development of AF. Finally, multiple logistic regression modeling, including all these parameters, revealed that only reelin might be associated with a twofold increased risk of developing postoperative AF, especially in women. So with all this, we can conclude that analyzing preoperative serum markers may help us to understand the mechanisms predisposing to the development of postoperative AF, to identify sex-specific markers to forecast the development of this complication, and to identify new therapeutic targets in patients with aortic stenosis elective for surgical valve replacement. Thank you.
Thanks, this is really cool. So what do you think?
Excuse me, I have a hearing problem.
Oh,
you
I'm
can
sorry,
get
yes.
closer to me, please.
So what do you think that reelin is doing biologically?
What I think,
Like
what?
how does reelin connect perhaps with a mechanism?
What is reelin doing biologically? What does it do in the body? Yeah.
Yeah, what do you think is
Sorry,
going on?
I couldn't hear the end of the question.
Okay.
So we have recently demonstrated in a recently published paper that reelin is associated with the development of aortic stenosis and is differently expressed in male and female. Overall, all the literature about this marker is being related to neurodegeneration and neurodegenerative disorders. And it's a lymphangiogenic marker, which we previously found it was increased in male during aortic stenosis, and now recently we have found as well that it's signaling reelin, particularly in the development of aortic stenosis. So in this case, it's true that I'm talking about postoperative atrial fibrillation, but we think that it might be related with the pathological status of the patients with aortic stenosis, specifically with aortic stenosis. Most of the literature, and this is like a brief introduction to people who doesn't know, most of the studies made on biomarkers for the prediction of postoperative atrial fibrillation have been done in patients, CABG patients, or very heterogeneous cohorts, including any kind of patient undergoing a surgical valve replacement, mitral valve prolapse, or whatever. So we think that because of the homogeneity of this cohort, we may add some relevance to the prediction of, and then the management of these patients. I think I've answered your question.
You did.
Okay.
Thank you.
Thanks.
All right, next, poster 19, Christina. And while Christina is getting set up, I wanted to check. Hyung, did you show up? No, okay. Hold on, keep going. This is very close.
All right. Hello and good evening, or guten Abend from Germany. My name is Christina and I'm here to present to you our data, which I'm very happy about, regarding repeated pulmonary valve replacement, PVR, in patients with repaired tetralogy of Fallot, short for TOF. As you know, patients with repaired TOF often have to undergo more than once a PVR in their whole lifetime. Yet optimal timing and long to mid-term results of these patients is still poorly defined. And that's the gap our study aimed to address. So due to the time, I'll focus on average results only. We retrospectively analyzed 89 patients who underwent their first PVR in our institution between the years of 2004 and 22. The follow-up time was around 10 years, and at the first PVR, 28% of the patients received a bioprosthesis and 71 a homograft. Interestingly, there could not be shown any significant difference in freedom of a second PVR between those two types of grafts. A second PVR was necessary in 28% of the patients, 13 underwent a surgical one, and 14% a catheter-based procedure. Freedom of redo PVR in this group was 90% after 10 years and 65% after 15 years, which you can see in the Kaplan-Meier curve on the left side. A third PVR was necessary in 9% of the patient, which was mainly performed on catheter-based procedure, and freedom of redo PVR a third time was 97% after 10 years and 82% after 15 years. However, we could identify one single independent risk factors for earlier and more frequent PVRs, which is a younger age at the first PVR, meaning under 15 years. The hazard ratio presented with a value of 3.9, meaning that those patients have a fourfold higher risk of repeated and earlier PVR over their whole lifespan. So in conclusion, we can say that PVR is generally common in those patients, and consistent with prior research, younger patients, especially under 15 years at first PVR, undergo earlier and more frequent reintervention. Especially those patients might benefit in the future of a more frequent follow-up and also a catheter-based intervention to elongate the time between first and maybe second PVR, and therefore limit and reduce future reoperations and improve mortality and morbidity. This is crucial information for follow-up visit and timing in patient care, and also family counseling during those visits. Thank you.
This is very, very comprehensive. Because you studied this over a long period of time.
Yes.
Were there any time-dependent effects over just like the early practice, later practice?
Mostly later practice.
Okay.
There were also some not very significant effects also, but the time was the most important factor.
Okay, very interesting. I like your recommendation. Thank you very much.
Thank you.
Okay, and then finally, we have, it's not flagged on here who the presenter is. Go ahead and introduce which author you are.
Good afternoon, everyone. I'm Jeff.
Jeff.
One of the authors. I'd like to thank everyone for the opportunity to talk in front of everyone this afternoon. As we know, pulmonic stenosis is relatively well tolerated towards adulthood. Even in pregnancy, it has been reported that severe pulmonic stenosis can be well tolerated. What makes this case noteworthy is that in this case, we do have a severe pulmonic stenosis previously undiagnosed. The patient came in at 34 weeks AOG. And so the patient came in with severe pulmonic stenosis and already with signs of right to left shunting. In this case, we suspect that the right to left shunting came much later and did not occur beforehand. Because in the case of this patient, the patient previously did not present with any exercise limitations, etc. However, upon the first prenatal visit at 34 weeks AOG, 2D echo was done, where it was found that the patient had severe pulmonic stenosis with a peak gradient of 219. Take note that in order for you to classify pulmonic stenosis as severe, you only need a peak gradient of 64. In this case, we have 219. But in the case of the patient had a progressive exertional dyspnea. However, the patient was not dyspneic at rest. And with medical management, the patient was placed on bed rest. Together with oxygen supplementation, the patient was relatively stable. And thus, the decision not to perform surgical procedure, in this case, also due to the limitation in our institution, was done. The patient was placed on bed rest together with medical management. However, the patient later on, there was a decision for the patient to give birth via cesarean section or via C-section before term, because later on during the routine screening, the baby was found to have intrauterine growth restriction, now presenting with fetal brain sparing effect, meaning the patient did not receive enough oxygenation. That was the indication for the patient to undergo C-section. After the C-section, the baby is relatively healthy, the patient had an unremarkable course, and the patient was therefore discharged with possible planning for an intervention later on. In conclusion, concurrent with the literature which has been published regarding pulmonic stenosis, even in severe forms, is relatively well tolerated in pregnancy. In this case, even though there's a right to left shunting, with medical management, the patient was relatively stable, and thus, in this case, severe pulmonic stenosis can be managed medically. However, this highlights the importance of in the case of our country, in the context of our country, where some patients do come in later during their prenatal visits, late in their pregnancy. There's an importance in the screening of patients for possible cardiac problems, because in the case of the patient, wherein the patient had severe progression of their disease due to the maternal changes, physiological changes in pregnancy. In this case, the patient was lucky because she had a remarkable course, but some patients may not be so. Thank you very much.
That's amazing. So have you seen anything like this before in your practice?
We do see patients with severe pulmonic stenosis coming in, but not like this, wherein the gradient is so great that there's already a right to left shunting. So in this case, because of the severe gradient, in pregnancy we do see a decrease in afterload and an increase in preload. Therefore, the natural foramen ovale actually opened because of that gradient. This is the first time we've seen that, and so we thought it well to report it.
Congratulations.
Thank you.
All right, thank you. All right. So this wraps up our poster session, e-poster session. I'd like to congratulate all of the speakers, and you did a marvelous job staying on time. It was very interesting. There was truly something for everybody, and we hope you have a wonderful rest of the night. Thank you.